So as we are all gathered here to share our clinical insights, to listen all the insights provided by our presenters, and I'm requesting everyone to grab the opportunity to listen carefully and pay the attention while presenting the case by presenters. So before going into the presenters, let me list out the presenters' name who are going to present today. That's Minal Bhagavate and Najiya Fatima from the PharmD 6th year. That's their and the case presentation by Jayanti Lalita from PharmD 5th year. I hope the presenters are ready with their presentations. So.
Okay, good afternoon, guys. I'm Najiya.
If the presenters are ready with their presentation, they can start now.
Right. So can we start now?
Yeah.
Hello. Hello, good afternoon, guys. I'm Najiya, and I'm here with Minal today to present our topic, pharmacotherapeutics presentation on stroke. Just give me a moment. I'll start sharing my screen. Yeah, I hope the screen is visible. Just a second, please. Yes. So guys, I hope you guys are with us today. So yeah, I hope you guys can be with us throughout the presentation. Let me start by defining what stroke is. Stroke is defined as an abrupt onset of focal neurological deficit that persists more than 24 hours and is attributable to a focal vascular cause. Stroke is now the leading, it's the second leading cause of disability worldwide after coronary artery disease, and it also is the commonest cause of chronic adult disability. The diagnosis of stroke requires clinical presentation and brain imaging, and the manifestations of the stroke are variable because it depends on the area of the brain that is being affected. The neurological symptoms manifest within seconds because neurons lack glycogen. So when there is a lack of any blood supply, since there is no glycogen, energy failure is rapid. And if the ischemia lasts for more than a few minutes, then there is a chance that due to the lack of oxygen and lack of blood flow, infarction of or death of the tissue might occur. Moving on to the epidemiology, and as I mentioned that it is the second leading cause of both disability, it is also the second leading cause of death worldwide. And the major burden of this disease is shared by low and middle income countries. Now, what do I mean by the burden of the disease? Is that once a person gets stroke, generally the patient doesn't really recover, but then they either get partially paralyzed, or they get paralysis, they get for the problems that stay with them for a longer duration of time. Those things come, and therefore that affect their ability to work or earn money. Therefore, the highest burden is being shared by the low and middle income countries. Now let's see how many strokes occur over here. Around 12.2 million new strokes occur every year, which is like, if we get it how many, so it's like one stroke is occurring every 3 seconds. And it is also seen that 1 in 4 people will have a stroke in their lifetime, and the number of people that are occurring with the stroke has increased 15% in the last 17 years. So in the last 17 years, the incidence of stroke has increased by 50%. And previously we used to assume that stroke is going to come to only the elderly population, but now that definition has changed, where the stroke is no longer a disease of the elderly, where 63% of the strokes that happened in the year 2019 were for the people of the younger generation, that is like the people less than 70 years old, had more stroke happening as compared to the people who were older. Now let's look at how do we spot a stroke, or how do we get to know a person is of the brain responsible for left side of the body, and left side of the brain is responsible for right side of the body. Okay, so if the right side of the brain is getting injured, then the symptoms are seen on the left side of the body. And if left side is getting injured, then the right side is getting affected. So the major symptoms that we see when a person is having stroke is we can see some facial paralysis and inability to move, take their arm up, or they're unable to speak properly. Speech language deficits are seen. They're unable to. The vision is impaired, or they're having issues. They're unable to recall much stuff. These are what we see on it. Now there was an acronym that was created to spot a stroke. That is, the acronym is B FAST acronym. So where B stands for balance, E stands for eyes, F stands for face, A stands for arms, S stands for speech, and T speech. So being balanced means that the person, when the stroke is occurring for a patient or a person, the person might feel dizzy, might feel headache, and they are not able to maintain their own balance. And they also experience something like blurred vision. One side of the face gets dropping. The affected one side of the face is dropping. As I mentioned, they're unable to lift their arms. So then we also see that there is an arm or leg weakness, and speech difficulties is also seen. Like they're unable to make proper sentences. They're not able to understand what we are trying to say, and they're not able to communicate anything. That is what speech difficulty means. So when we see all of these symptoms in a person, then it's important that we call the ambulance immediately and give the proper care, and make sure that the proper care is being received for the patient. Now moving on to what are the risk factors. The risk factors are, there are 10 leading risk factors in the world, which is, first one is elevated systolic blood pressure, high body mass index, high fasting glucose, air pollution, smoking, poor diet, high LDL cholesterol, kidney dysfunction, alcohol, and low physical activity. These are a few of the risk factors. Now these risk factors can also be divided based on modifiable and non-modifiable risk factors. What does modifiable and non-modifiable means? Modifiable are those ones that, if you try maintain a certain lifestyle, get active and involve, get exercise ourselves, monitor these risk factors like hypertension. If we monitor hypertension, if we reduce smoking, monitor our BMI, monitor our weight, and monitor our diabetes, make sure all of these risk factors are under a limited, under the normal limits, and just take a healthy life measures, then we can always reduce the risk of stroke happening. Now, what are the non-modifiable risk factors? That includes age, race, sex, family history of stroke, or transient ischemic attack. And now, age is that we know that with increasing age, the risk of stroke increases. Considering the race, there is an increased risk of stroke in blacks and the Hispanic population. Now, why is it so? Because the blacks and the Hispanic population, they have a gene that is salt sensitive. Since the salt center, so even if they're having less amount of salt, the risk factor for the risk associated with their salt intake is increased. So with that, these blacks and Hispanics, they also have an increased, increased rate of having like increased blood pressure and heart diseases. The incidence is more in the blacks and Hispanic population. And then sex may we have increased risk in men. Moving on to the classification of stroke, we have two types of classification. One is clinical classification and the second one is the mechanical classification. In the clinical classification, the stroke is divided into three main types. That is the completed stroke, evolving stroke, which is also known as progressive stroke, and transient ischemic attack. The completed stroke is the one in which the symptoms or the focal neurological deficit that is forming, they are now like, they are set, they're persisting over time, and they're not worsening over time. In the progressive stroke, we see that the focal neurological deficits worsen with time. Now, what is transient ischemic attack? A transient ischemic attack is that all the neurological symptoms that is occurring, they resolve within 24 hours, and also there is no effect or like no change in the brain imaging. So that is what is transient ischemic attack. In transient ischemic attack, the blood flow is also quickly restored, and the brain tissue recovers full, and patients are not having any other future symptoms. But if the stroke occurs and if the stroke symptoms and signs last more than 24 hours, then it's categorized as stroke. What differentiates transient ischemic attack with stroke is the duration of symptoms. If it is less than 24 hours, then it is transient ischemic attack. And if it's lasting more than 24 hours, then it is stroke. The risk of stroke after transient ischemic attack is approximately 10 to 15% in the first 3 months. Moving on to the mechanical classification or the second classification, that is stroke is, there are two types, that is ischemic stroke and hemorrhagic stroke. Ischemic stroke is due to the reduction in blood flow, And hemorrhagic stroke is due to a rupture of blood vessel, which is causing bleeding that is occurring in the brain parenchyma. In the ischemic stroke, there is two types: the thrombotic stroke and embolic stroke. In hemorrhagic stroke, we have intracerebral hemorrhage and subarachnoid hemorrhage. Let's look at the few pictures for hemorrhagic stroke and ischemic stroke. In this, we see that in the hemorrhagic stroke, the blood vessels rupture and the bleeding occurs inside or around the brain tissue. In the ischemic stroke, blood clots form inside the cerebral blood vessels, which are blocking the flow of blood into the brain tissue, which is leading to ischemic attack, like causing ischemia in the affected area. Now, ischemic stroke, as mentioned, it occurs when a blood vessel that supplies the brain becomes blocked or clogged, and it impairs the blood flow to the part of the brain. And within minutes, if the lack of blood, oxygen and nutrients is there, the brain tissue dies within minutes. And the area of the tissue there, that's like the main area where the tissue that is occurring, that place is also known as infarct. Around the Now, as mentioned, thrombotic stroke is thrombus, that is, a blood clot is being formed in the blood vessel that is blocking the flow of blood. In embolic stroke, that is, the blood clot is developed somewhere else in the body and it travels to one of the blood vessels in the brain and it is blocking the certain structures in the brain. That's the embolic stroke. What is hemorrhagic stroke? Hemorrhage meaning bleeding, right? So it is these occur when a blood vessel is ruptured, blood vessel that supplies blood to the brain is ruptured and a bleeding is occurring. So there are two types, subarachnoid and intracranial hemorrhage. The subarachnoid hemorrhage occurs when blood enters the subarachnoid space, that is the space between the brain and the tissue that covers the brain. That's my space. So the bleeding is occurring in the space where the cerebrospinal fluid is housed. This may be due to trauma, rupture, or that is maybe due to trauma that is occurring, or rupture of the intracranial aneurysm or AV malformations. Intracranial hemorrhage is that the bleeding is occurring within the brain parenchyma, which results in the formation of a hematoma. This can be because of a high blood pressure. Sometimes it is mainly because of high blood pressure. Moving on to what could be the causes of stroke. Ischemic stroke and hemorrhagic stroke. So ischemic stroke can be caused by atherothrombotic, that is atherothrombotic because that is nothing but blood clot in the arteries. Atheroembolic is occlusion of small arteries in the kidneys. Cardioembolic is blood clots that is like being formed, and then the emboli, that's because of an emboli, and miscellaneous reasons. Intracerebral hemorrhage, as mentioned, it could be because of hypertension, AV malformations, and head injury. Subarachnoid hemorrhage could be because of AV malformations, ruptured cerebral aneurysm, and head injury. What are AV malformations? That is like the blood vessels are getting intertwined. Or you can also say that there is an abnormal connection of blood vessels between arteries and veins. Arteries and veins, there is an abnormal connection. Therefore, that is nothing but what is arteriovenous malformations. Moving on, this is a CT scan of what a stroke might look under the CT. In the ischemic stroke, the black portion or the darker portion of the brain that you're seeing towards the left side, that is what represents the ischemic stroke. The hemorrhagic stroke is being seen that the bleeding is being seen as the white part of the brain. So if we see within the brain tissue, if there is the white lining or the white liquid, white stuff that is we seeing, that is the bleeding, that represents the bleeding that's occurring in the brain. Now, the incidence rate of among all of the strokes that are occurring, 85% of the strokes are ischemic strokes and 15% of the strokes are hemorrhagic strokes. But although the incidence of hemorrhagic stroke is less, they are more deadly and they are more lethal than ischemic strokes. Now let's study the pathophysiology of ischemic stroke. Now, as mentioned, that when ischemic stroke is occurring, there is reduction in blood flow, which limits glucose or oxygen into the neurons. This causes an energy disruption, which causes mitochondrial dysfunction, triggers reactive oxygen species formation, and oxidative stress-induced damage. So, first we have the first process that starts is the excitotoxicity. There are four processes when we are understanding the ischemic stroke. There are four steps that is happening. That is excitotoxicity, cell death signaling, neuroinflammation and blood barrier breakdown, oxidative stress, and mitochondrial dysfunction. In excitotoxicity, because there is a release of excessive glutamate is being released here, which goes and activates the N-methyl D-aspartate receptor. When this is being NMDAR receptor is getting activated, this NMDAR receptor is responsible for toxicity and cell death. So when glutamate is being released and which is causing activation of NMDAR, it is causing cell death and toxicity. And then once that occurs, the next step is the cell death signaling that can be activated by autophagy or apoptosis. Autophagy or apoptosis. The next step is the neuroinflammation and blood barrier breakdown. That is because here in this step, all the immune cells and the inflammatory cells markers, they come in and they get activated, and then they cause further blood barrier breakdown. And that is by the immune cells like the cytokines and chemokines. These contribute to the further breakdown of the blood-brain barrier. When this is happening, then the next step is the oxidative stress or mitochondrial dysfunction. Oxidative stress is characterized by reactive oxygen species production and which causes mitochondrial dysfunction. And as mentioned, now let me just summarize. Ischemic stroke is nothing but in ischemic stroke, there is a decrease in the oxygen supply to the particular area of the brain that is being affected, which is causing lack of glucose and oxygen. And when the stroke is occurring, the main area where there is the blockage is there, main area that is being affected, that is the ischemic core. The area surrounding the ischemic core is the penumbra region, where not much effect is being little effect is there, but not much effect is being seen. And the periphery is the region that's the normal blood tissue which is not been affected by the ischemic attack. As we see in the periphery, we see intact blood-brain barrier and healthy neurons are present. In the penumbra region, as the effect of ischemia is still seen, but the effect of ischemia is not much. We see blood barrier breakdown and immune cell infiltration is being seen, and the dead cells are undergoing like the apoptosis and everything is going on. In the ischemic score, we see that the cell necrosis has happened, immune cells have infiltrated, and there is a blood barrier breakdown. Let's look at the pathophysiology of hemorrhagic stroke. As hemorrhagic stroke means that there is bleeding that is occurring inside the brain. So there is a huge amount of blood volume that is coming through the brain parenchyma, or in the brain tissue. There is a huge amount of blood that's forming, which disrupts the neurons. The white matter fiber tracts that are present, they get split up, which causes cessation of the neuronal function. If the hemorrhage is large, the hemorrhage, because until unless the bleeding is being stopped, the hemorrhage gets expanding, like it's still expanding, which causes a mass lesion and further progresses which causes the further progression of neurological deficits. This causes large hemorrhages, causes transtentorial coning and rapid death. What is transtentorial coning? This is also known as transtentorial herniation. That is a condition where, due to high pressure inside the skull, a part of the brain is squeezed across other structures in the brain. This causes rapid death. Let's look at the diagnosis. For the diagnosis, there are certain imaging scans, a heart and blood vessel test, and swallow test. In the imaging scans, we have CT scan. CT scan helps differentiate ischemia and hemorrhagic stroke. MRI scan is used in people with complex symptoms where the extent or location of the damage is unknown. Heart and blood vessel test, we have carotid ultrasound and echocardiography. In carotid ultrasound, we should check if there is any narrowing or blockages in the carotid arteries. In echocardiography, we check the heart image. We make images of the heart to check if any problems could be related to the heart. Swallow test. Essentially, when anybody is having a stroke, the ability to swallow is affected. So, if the person cannot swallow properly, then there is a risk that the food or drink might get into the windpipe, which can lead to chest infections such as pneumonia, and it is called as aspiration. So, the swallow test is done to check again, to just see if the person is getting better. Also, to assess if the person has had a stroke. Moving on, the next part of the presentation will be taken up by Minal.
Okay, guys, so you all have understood like the what is stroke, the symptoms, signs, and the pathophysiology. Let's move on to the pharmacotherapy. Before moving on, we'll look into the goals of therapy, like reducing the ongoing neurological injury, to decrease the mortality and long-term disability, prevent further complications and neurological dysfunctions, and to prevent the reoccurrence of stroke. So, in non-pharmacological therapy, we can perform three therapies, like speech therapy we can perform. In therapy, what we can do, as we have learned that in stroke, there is neuronal deficits. So, we have to check that the person is comfortable, and by practicing relaxation and other communication styles, and using different gestures and tone, we can help patient to get back to the regular speech. Then secondary is the physical therapy. There is what we can say, there we have to perform like relaxation therapies. We have to get patient to the normal coordination of the body. So physiotherapists can help us in doing that thing. Then in occupational therapy, we can also perform, we can help a patient to improve their ability to carry out their day-to-day activities, such as taking bath, cooking, dressing, eating, or another day-to-day activity. So these are the non-pharmacotherapies which we can perform. Moving on to the non-pharmacological therapies. Next slide, please. Yeah. So, as we all know that the source of ischemic stroke can be two, that is thrombotic, that means the clot that is formed into the brain, and embolic. Then there is a cardioembolic also, that is the clot that is formed into the heart, but it has traveled, or any other clot that has been formed in the body. So the purpose of this, for this purpose, we have a primary treatment, that is giving TPA, that is altiplase. We can give 0.9 mg per kg IV. The max dose of altiplase that we can give in stroke patient is 90 mg. Tissue plasminogen activators can be only given within 3 hours of onset. So we have to take care of this. So can anyone tell what are the conditions or things that has to be taken into consideration before giving TPAs? What are the conditions we have to check? Okay, so before giving tissue plasminogen, we have to check like if there is any intracranial hemorrhage, subarachnoid hemorrhage is there high blood pressure, or is there any active bleeding going on into the patient? Why this is necessary? Because tissue plasminogen activators, they will break the clot, and this will increase the risk of bleeding. So we do not want to increase the complication. Here is the list of inclusion criteria and exclusion criteria of tissue plasminogen activators in patients. So we have to take this into consideration. Previous slide, please. Then after done with TPAs, we need such an agent which will avoid platelet to stick to the clot onto the side of injury or infarct. So for that reason, we have to take antiplatelet agents. We can take aspirin, clopidogrel aspirin, 160 to 325 mg daily. We have to take aspirin. In aspirin, it is that aspirin has to be taken within 48 hours of onset. Uh, then secondly, after looking into another parameters also, if the patient is hypertensive, we have to look into we have to take antihypertensive agents. Even if the patient is do not have the history of hypertension, if he is not the known case of hypertension also, we have to give antihypertensive agents as a prophylactic agent, because we do not want hypertension to increase, like shoot up of blood pressure and the further bleeding of the vessels. So we have to give antihypertensive as an prophylactic agents. Then if, for dyslipidemia, we have to give, because there is plaque formation. So for that reason, we can give statins. If the patient is having high blood sugar levels, if the patient is diabetic, we can give patients on insulins for the initial stage, and after that we can shift switch the patient on oral hypoglycemic agents. If the source of emboli that is there is a cardiac source, so in that case we can give warfarin also. These all was the drugs that we can give. Further, we can also perform surgeries in patient. Next slide. Next. One second. These are like the standard guidelines for the ischemic stroke. As I have told, in acute primary treatment is tissue plasminogen activators, and within 48 hours we have to start the patient on aspirin. For secondary prevention for cardioembolic sources, we can give antiplatelet agents. For cardioembolic source, we can give oral anticoagulants. For atherosclerosis, for we have to maintain blood pressure also. For that, we can give antihypertensives. Next slide. So these are the surgeries which we can perform in acute ischemic stroke, that is thrombectomy, carotid artery stents, carotid endarterectomy. In thrombectomy, what is there that we have to put the stent into the vessels, and we can suck out the clot over there. In carotid artery stent, we perform in heart surgeries, we have to place a stent where there is injury, and we can increase the diameter of the vessel. In carotid endarterectomy, what we do, we manually remove the plaque from the site. Next slide, please. Then there is hemorrhagic stroke. In hemorrhagic stroke, before going into management, we have to look into the cause of the hemorrhage. Like if the patient was on any anticoagulant therapy or not. Why this is important? Because if he is on anticoagulant, the risk of bleeding may be there, and that might be the cause of hemorrhage. So if he was taking any anticoagulants, then we have to reverse the bleeding. Then how we can reverse the bleeding? By looking into which anticoagulant was he on. Like if he was on warfarin, we have to give the patient vitamin K. If he was on heparin, we can give protamine sulfate. If he was on TPAs, then we can give tranexamic acid. So before going into anything, we have to check like what was causing the hemorrhage. Okay. If anticoagulants were not the cause, then we have to give antihypertensive. And antihypertensive, what we can give nicardipine, labetalol, hydralazine. And in hemorrhagic stroke, we have to aim that the blood pressure of the patient, the systolic blood pressure, should be below 140 mm of Hg. And we can give nimodipine 60 mg every 4 hours for 21 days. So in hemorrhagic stroke, what happens in any stroke, I can say, the irrespective of the type of stroke, there is the buildup of intracranial pressure inside the brain. So for that reason, we can give mannitol or 23.4% hypertonic solution. A fresh frozen plasma we can give. Prothrombin complex concentration can give. FFP and PCC are both the agent which will decrease the bleeding. And PCC we can give when we have to perform a surgery within a next 6 hours, or if when the fresh frozen plasma is not giving that suitable effect. So in that case, we can also give PCC. Next slide. So these are the surgeries which we can give in hemorrhagic strokes, that is craniectomy. Craniectomy is also performed in those patients in which the intracranial pressure is built up too much. In this surgery, the outer cover of the brain is removed, and which will, in that case, the brain will swell, and ultimately the intracranial pressure inside the brain will decrease. Secondly is evacuation. In evacuation, where there is a leakage in the brain, we suck it out. In clip ligation, it is mainly performed in subarachnoid hemorrhage. The major thing that we have to look into consideration while performing clip ligation is monitoring the blood pressure of the patient. We have to check like if the blood pressure is to be normal. Why? Because if the blood pressure is not normal and we clip ligate that vessel, then there is chances of bursting of the vessel due to high blood pressure. So the most important thing while giving clip ligation is to check the blood pressure. And if the blood pressure is high, we have to maintain the blood pressure, and then only we can perform clip ligation, right? Next slide. So we all know the mechanism of action. Still, I will go through it once again. So moving on to mechanism of action, LT plays, as I said, 0.9 mg per kg we have to give. Max dose is 90 mg. And the dosing is like the 10% of the total dose according to the kg per weight, body weight of the patient. 10% of the bolus dose we have to give in first 1 minute. And the remaining 90% what is there, it has to be given into the infusion over next 60 minutes. The thing with altiplase is that altiplase is a thrombolytic agent that has to be given under the ICU treatment, ICU facilities, because the chances of bleeding is there. So we have to maintain a proper suitable things. So, and after giving altiplase, we have to go for a CT scan of the patient within next 24 hours. This is also due to because there is chances of bleeding. So we have to check if there is further worsening of the condition, if there is bleeding. So we have to monitor that. So how it works, it activates fibrin-bound plasminogen which is there, which will convert it into plasmin, and plasmin will further degrade the fibrinogen and fibrin. The most common side effect of TPA is what? It is bleeding. Okay, so aspirin is there, which has to be given within 48 hours of stroke. And it is done by inhibiting the conversion of arachidonic acid to thromboxane A2, which will prevent the platelet aggregation, right? The dose is 160 to 325 mg OD, which can give. Clopidogrel we can also give, which will reversibly block the P2Y12 receptors, components of ADP receptors on the platelet surface, which will prevent the activation of GP2B and GP3A receptors complex, and thereby preventing what? Platelet aggregation. Apixaban, it acts by directly inhibiting factor 10A. As we know, the coagulation cascade, it directly inhibits the factor 10A, and the dose is 5 mg BD. Atorvastatin, it acts by inhibiting HMG CoA reductase, and dose is 10 to 20 mg OD. Next slide, please. Then at antihypertensive, we can give labetalol 10 to 20 mg. The max dose is 300 mg. The frequency which we can give is like 10 to 20 mg we can give over first 1 to 2 minutes, followed by 20 to 80 mg every 10 minutes, until we have to give this dose until the blood pressure has been controlled. It acts by blocking alpha 1, beta 1 and beta 2 adrenergic receptors. Then next is nicardipine 5 mg per hour we can give. If it is tolerated, we can increase it. 5 mg is increased over 2.5 mg per hour at 5 to 15 minutes interval. It acts by inhibiting transmembrane infusion of extracellular calcium and inhibit contraction and thereby dilating main coronary arteries. Nimodipine is a drug that which we give in mainly in a hemorrhagic stroke. A preferred drug that has to be given, and dose is 1 mg per hour for 2 hours. If tolerated, we can increase it to 2 mg per hour. In hemorrhagic stroke, there is a vasospasm, so nimodipine is the best choice that has to be given. It inhibits calcium entry into the smooth muscle, resulting into the inhibition of vasoconstriction. Next slide, please. So these are the complications of stroke. That is aphasia, depression, ho gaya, anxiety, aprasia. So we can give for depression fluoxetine, for aphasia. Then SSRIs we can give for anxiety and all. Next slide, please. Then there are some lifestyle modification or stroke prevention things, like quit smoking or use of tobacco. Improve eating habits, like eat food that is low in saturated fat or sodium, like to maintain the blood pressure, and less sugar, or avoid as much as sugar you can in diabetic. So because it will ultimately increase the complication. We can include fruits, vegetable, whole grains, dried beans and beans in the diet of the patient. We can counsel the patient regarding the being physically active, like minimum patient can do a 3-day exercise in a week. वैसे तो रोज करना चाहिए थोड़ा थोड़ा, but still minimum 3 days exercise is required. And we have to counsel the patient about the antiplatelet therapy what he is taking, or because it has to be taken regularly on the regular time that is he has been taking. And the most important thing is that we have to counsel the patient regarding the stress management, because stress is the primary thing for the stroke, whether it be the ischemic stroke or hemorrhagic stroke. So, by reducing stress, the ultimate complication can be reduced, and proper monitoring of blood pressure and sugar should be there. So, this was all about stroke. Thank you, guys.
No, Mohit. Actually, is that antihypertensive agents are only given when a patient, the cause of bleeding or any stroke that is occurring is due to high blood pressure. In that cases, antihypertensive agents are being given. Guys, do you have any other questions? Thank you, guys.
Good evening, everyone. Am I audible?
Yes, you are.
Yeah. I'm here to present a case on stroke with the comorbidity of chronic kidney disease and systemic hypertension. As we all know, stroke is classified as hemorrhagic and ischemic. There are two types. Hemorrhagic happens when arteries bleed inside the brain, and ischemic happens when the arteries get blocked. In hemorrhagic stroke, one second. In hemorrhagic stroke, there are two types: intracerebral and subarachnoid. In the intracerebral, the bleeding occurs in the cerebrum, and in the subarachnoid, the bleeding occurs between the pia meter and the arachnoid meter. So this patient is a 55-year-old male who weighed 60 kgs and was 160 centimeter in height. He was admitted for the chief complaints of fever for 2 days, altered sensorium and speech disturbances, inability to move his right limbs, and also had a history of self fall 2 days ago. He had a past medical history of chronic kidney disease stage 4 and was on dialysis for 2 times, but he did not continue after that. He also had systemic hypertension for the past 2 years, but was on irregular medication. On physical examination, he was observed to be oriented, drowsy, febrile, and thin-built. On checking his vitals, the BP was elevated. It was 150/80, and his pulse was 100 beats per minute, and his temperature was 100 as he was febrile. And on systemic examination, everything was normal except the CNS, which as he had right-sided paralysis. On laboratory investigation, his hemoglobin was found to be 7.15 gram per deciliter, which indicated that he was anemic, and his polymorphs and lymphocyte levels were abnormal, indicating an infection. His blood urea and serum creatinine levels were also abnormal, indicating he had kidney disease. On CT scan, it was observed that he had hematoma in the left frontal region, which explains the right-sided paralysis. And on assessment, the final diagnosis was made to be hemorrhagic stroke uh, with chronic kidney disease, which is stage 4, and systemic hypertension. The treatment plan that was given to him was the goal of the plan was to resolution of the clinical signs and symptoms, to slow or prevent the disease progression, and to improve the quality of his life. The standard treatment which should be given for a hemorrhagic stroke is that the management of blood pressure, the management of the intracranial pressure, surgery, and cerebroprotection treatment. As we all know, in hemorrhage, during an hemorrhage in the brain, the pool of blood from the damaged vessels is formed in the brain. Hence, the intracranial pressure increases. So the pressure in the nearby tissues and the nearby blood vessels also increases. This indicates the low blood pressure in the downstream blood flow. Hence, the healthy tissues in the downstream are deprived of oxygen. Hence, the healthy tissue either die because of the direct pressure or because of the lack of oxygen. And the symptoms we should notice in a stroke patient is, as they mentioned before, fast. F indicates facial drooping, A for arm weakness, S for speech difficulties, and time indicates that it like we should call for ambulance immediately or for emergency immediately. On the standard treatment guidelines to reduce for the blood pressure management, we should provide beta blockers, ACE inhibitors, calcium channel blockers, or hydrolyzine. And the BP should be checked regularly and should be gradually reduced to below 150 to 90. 150 by 90. And for the management of raised intracranial pressure, the head should be elevated and mannitol should be provided. Surgery options differs. It depends upon uh, it can be craniotomy or stereotractic aspiration or catheter aspiration. It depends, and the cerebroprotection is also provided to reduce the oxidative stress. And for the treatment of the chronic kidney disease, the underlying disease condition should be initially treated, like hypocalcemia, hypermagnesemia, hyperphosphatemia. Everything should be treated. Like, this patient had anemia, and standard treatment guidelines indicates that we can provide iron supplements to improve the anemic levels. On admission, the patient was given injection furosemide injection in 20 mg and in injection ceftriaxone for the treatment of the infection, as his polymorphs levels were elevated. And injection ranitidine is given as H2 receptor blocker. Tablet amlodipine and tablet atorvastatin is given to reduce the intracranial pressure, to reduce the high blood pressure. Tablet paracetamol is a COX-2 inhibitor, which is provided as he had fever. Tablet clopidogrel and tablet aspirin are antiplatelet agents. And tablet calcium plus vitamin D3 is given as the calcium supplement for calcium and vitamin supplement for kidney disease. On discharge, ranitidine, furosemide, amlodipine, clopidogrel, atorvastatin, calcium, and aspirin was given. On day one, the patient was drowsy and but he was oriented. On day two, he was suggested for dialysis and limb physiotherapy as it was identified as hemorrhagic stroke. On day three, the patient had body pain and limb physiotherapy was provided. And on day 6, again dialysis was advised and limb physiotherapy was provided and he was discharged. Monitoring parameters are for furosemide, it is liver function test, renal function test, sodium levels, and CBC. And as the toxicity can be thrombocytopenia, photosensitivity, and Steven-Johnson syndrome. For ceftriaxone is CBC and heart rate because it can cause anaphylaxis, pruritus, nausea, and vomiting. For ranitidine, it is CBC, endoscopic improvement, and abdominal examination, and as it can cause abdominal pain and pancytopenia. For amlodipine, it is BP and ECG and lipid profile because it can cause tachycardia, headache, and chest pain. For paracetamol is LFT, CBC, and body temperature as it causes GI bleeding and hepatotoxicity. For clopidogrel, it is CBC, heart rate, and ECG because it can cause bleeding, heart failure, and chest tightness. For atorvastatin, it is lipid panel and LFT because it can cause arthralgia, diarrhea, and dermatomytosis. For calcium and vitamin D3, it is RFT and calcium levels. And for aspirin, it is CBC, LFT, RFT, urine analysis, stool analysis. All these because bleeding is a common toxicity, and we should monitor the stool for dark stools as it can symbolize the internal bleeding. The patient counseling was provided for stroke and chronic kidney disease. Cerebrovascular accident is the medical term for stroke. It is the most common type of CVA. If the ischemic stroke occurs because of the blockage in the brain, and hemorrhagic stroke occurs as a result of bleeding in the brain. A hemorrhagic stroke is when there is uncontrolled bleeding inside of the brain and the space between the brain and its outer covering layer. This kind of stroke is especially severe and can get worsen quickly. Immediate medical attention is absolutely critical to provide prevent permanent brain damage or death. On drug-based counseling, injection ceftriaxone is given as an antibiotic to treat certain infections. On taking this drug, the patient might feel rash, itching, and swelling, and can have trouble breathing. We should advise the patient to inform if these symptoms get severe. On taking ranitidine, uh, experience headache or dizziness. If the symptoms are severe, he should be advised to report. On taking injection furosemide, this is given to increase the urine output, and the side effects like hypertension, frequent urination, photosensitivity can occur. Hence, we should advise the patients to use protective gears and sunscreens. Amlodipine, this is a drug given to treat high blood pressure and chest pain. Side effects include swelling, flushing, and dizziness. We should advise them to report it promptly. Paracetamol is a drug given to reduce the body pain and fever. Overdose or toxicity might lead to hepatotoxicity. Hence, the patient should take only based on the prescription. And tablet clopidogrel is given to prevent the blood clots and the occurrence of stroke. And taking clopidogrel, we should monitor for bleeding, and we should advise the patient to report symptoms like dark stools and bleeding from gums also. Tablet atorvastatin is an HMG CoA reductase given to reduce the risk of heart disease. We should advise the patient to report unusual muscle pain, fatigue, and chest tightness. Aspirin is also an antiplatelet given to reduce the risk. Uh, we should advise the patient not to take it on empty stomach and not to take it with other OTC drugs. Lifestyle modification that should be advised are DASH diet and renal diet. DASH diet is the Mediterranean diet, and renal diet includes bland diet with less oral fluids. And the patient should avoid smoking, prevent alcohol consumption, and should take low protein diet. And the liquid intake should be less than 750 ml per day. Uh, Ask the patient to reduce the protein intake like chicken, eggs, etc., and also to limit the salt intake to 1500 to 2300 mg per day, and to also limit phosphorus rich food to prevent mineral imbalances. Pharmacist intervention, I have intervened that this prescription is irrational as the treatment chart has a drug-drug interaction. Aspirin and clopidogrel can produce additive effects on concurrent use. It may produce increased risk of bleeding, and that's why it is important that we should monitor for bleeding and dark stools or GI or gum bleeding. And in this case, there was no ECG test was performed to identify if the condition was cardioembolic or non-cardioembolic, and there was no culture test performed. We found the polymorph levels was abnormal. The non-treated complaints are the patient is anemic, but no iron supplement is provided, and tablet paracetamol was given for almost 6 days and also during the discharge. But the body temperature of the patient got normal on the fourth